Hello everyone, today we'll be doing some clinical examples and we'll see how to use peak and plateau pressures in your patients. So we have a 50-year-old smoker with history of heart failure, pneumonia and intubated for hypoxemia. These are his vent settings. His PEEP is at 5, his plateau seems to be 16 and peak pressure seems to be around 32. You perform an inspiratory pause and you observe this. What you're seeing is there is no plateau that is happening even with prolonged inspiratory pause. So there must be a leak in the circuit. And whenever we think about leak in the circuit, the first thing we do is check for cuff leak, auscultate the throat for air leak. You can also look at the expiratory volume on the ventilator and see if it is lower than the tidal volumes that you are giving the patient, and the difference will give you the amount of air that is leaking. Check the cuff pressures, and clinically you can sometimes notice frothiness in mouth and nose that is coming from cuff leak. Second thing to look for is if there is a chest tube. Patients with bronchopleural fistula or persistent leak in the chest tube will not show you any plateau because air is continuously leaking outside the lungs. If you do not find any cuff problems or there is no chest tube, most likely there is either leak in the endotracheal tube or in the ventilator circuit. So ask your respiratory therapist to check the ventilator tubing. Here we have a 50-year-old smoker with heart failure, admitted with pneumonia and intubated for hypoxemia. And these are his vent settings. Peak and plateau are similar to the previous patient. You're called for peak pressure alarm, hypoxemia and low blood pressure. You perform an inspiratory pause and you notice that the plateau has increased while the peak minus plateau appears to be the same. So this is suggestive of decreased compliance because you see increased plateau minus PEEP. Whenever you see problem with compliance, look at the flow time waveform and see if the waveform is reaching baseline, and in this case the answer is yes. The common theme for decreased compliance is loss of alveoli, and this can happen because of three reasons. Either you have bronchial obstruction and therefore all the air from the alveoli has been absorbed, leading to its collapse, compression from outside, for example pleural effusions, ascites, abdominal compartment syndrome, etc., or they are filled with something, either water, pus, blood or cells. Next step is to examine and auscultate these patients, and you always make sure you suction the endotracheal tube for secretions yourself. Ask for a chest x-ray while you get your bedside ultrasound, and with the ultrasound you are looking at the lungs for sliding sign, B lines and effusions. So you saw lungs sliding, there was no pleural effusion, there were 2 to 3 B lines, which is normal. Chest x-ray shows white out of the right lungs with trachea and heart pulled to the right side. So the diagnosis is decreased compliance from lung collapse from secretions. What do? Most important thing is to maintain the SATs more than 90%, and you perform an emergent bronchoscopy to suction out the secretions, send the cultures for samples, and to prevent further events, start them on some N-acetylcysteine nebulizers if the secretions are thick, and make sure you are performing regular suctioning. Secretions are pretty interesting because they can cause issues with both increased resistance and worsening compliance. If you got airway narrowing from the secretions, you will see increased resistance. However, if you see that the secretions are completely occluding the airway, and which has resulted in alveolar collapse, you will be seeing worsening compliance. Our next patient is a 50-year-old smoker with heart failure, admitted with pneumonia and intubated for hypoxemia. So you came this morning and performed inspiratory pause and you found this waveform. There are a couple of things to notice. The first thing you notice is the pressure at the baseline is not at that what you set at, it is higher than PEEP. The compliance is certainly slightly worse than before, but also the resistance has gone up. Peak minus plateau is up and plateau minus PEEP is up. So what you're dealing with here is intrinsic PEEP. The intrinsic PEEP always occurs from an obstructive component. So you look at the flow time waveform and what you see that the expiratory flows are not coming down to 0. So you go ahead and perform an expiratory pause to calculate the magnitude of intrinsic PEEP. Go ahead and auscultate your patient, suction the endotracheal tube, look for kinking, biting and other signs of obstruction, and check capnogram if available. You can order a chest x-ray which can show some hyperinflation. Bedside ultrasound usually is unrevealing. On suction, you did not find any secretion. Patient is nicely sedated, no kinked tube. Chest X-ray shows hyperinflation and pneumonia. So your diagnosis is autopeep, and possibly somewhere there is some obstruction. The worsening of compliance is coming from autopeep, since pneumonia was already present before when he was intubated, and we don't see any element of collapse that would worsen the compliance. You have to give the patient enough expiratory time, decrease the respiratory rate, increase the PEEP to counter autopeep, decrease eye time and tidal volume, clear off the secretion, use bronchodilators and treat COPD. Decreasing the respiratory rate will certainly increase in PaCO2, and it will be absolutely okay to tolerate higher PaCO2 and pH more than 7.15. If you want, you can look up my previous lecture on how to improve PaCO2. Once you make appropriate changes, your expiratory flow rate should improve. However, it's not always that your flow rates would come down to zero. Next, we have a smoker with heart failure and COPD exacerbation, intubated for hypoxemia. When you perform the inspiratory pause during the morning rounds, you see that the peak minus plateau has increased. Plateau minus PEEP seems to be same, and the baseline pressure seems to be slightly higher than what you are providing the patient. What you are seeing is increased resistance because you see peak minus plateau is high, and there is certainly some component of autopeep. Step 1, just like before, look at the flow time waveform, and you see that expiratory flow is not reaching the baseline, and you perform an expiratory pause to calculate the intrinsic PEEP. Similarly, auscultate, suction, and check capnogram. You can perform X-ray and ultrasound as well. So there were no secretions in the endotracheal tube, there was no biting or kinked tube, and chest X-ray shows mostly hyperinflation. So this is a worsening bronchospasm. You do the same thing what you did with the autopeep. You give them a little bit more time to exhale. You increase the expiratory time by reducing respiratory rate, eye time, and tidal volume. You can increase PEEP to counter some of the autopeep. Treat your COPD exacerbation. Similarly, you can tolerate higher PaCO2 if pH is more than 7.15. Let's do another example. Here we have a 50-year-old with heart failure, admitted with drug overdose and intubated for airway protection. You are called for peak pressure alarms, worsening hypoxemia and hypotension. What you notice on the inspiratory pause is plateau minus PEEP, that's the compliance has worsened. Peak minus plateau seems to be same. So there is a worsening compliance, and similar to before, you run your differential. Look at the flow time waveform quickly, and you see that the flow is certainly coming down to zero. Look at the chest wall, auscultate, look for decreased breath sounds and crackles, suction the endotracheal tube, and ask for the chest X-ray while you get your bedside ultrasound. Look for sliding sign, B-lines, and effusions. On exam, you did not hear any lung sounds on the left side, and you did not see the lung sliding sign on the left side as well. There were no pleural effusions, so most likely you are dealing with left side pneumothorax, and chest X-ray confirms it. So what you do is you ask for chest tube set as soon as you made the diagnosis with your exam and ultrasound. You don't have to wait for the X-ray for confirmation. If you think that the patient is hemodynamically unstable, go ahead and perform needle thoracostomy. Otherwise, maintain the SATs more than 90% and perform emergent chest tube placement. To reduce the mean airway pressure, we will be reducing PEEP and reducing tidal volume. We have a 50-year-old smoker with EF of 40%, cocaine overdose, and intubated for airway protection. And these are the vent settings. Everything looks okay right now. You are called for peak pressure alarms again, worsening hypoxemia and hypotension. And again, what you notice is increased plateau minus PEEP, while peak minus plateau appears to be the same, and your baseline pressures are similar to PEEP. So what you're dealing with is decreased compliance because you see plateau minus PEEP is high. You go through the same process, examine them, auscultate them, suction endotracheal tube, get a chest X-ray, and get your bedside ultrasound. On exam, you hear crackles. On ultrasound, you see multiple B-lines. There is no effusion. The EF on the echo seems to be much lower than before at 20%. Heart rate is 150, and you notice that patient is in atrial fibrillation. Chest X-ray shows pulmonary edema. Your diagnosis is worsening compliance from pulmonary edema, Here you evaluate the cause for acute LV failure. So you order for an echo, EKG, cardiac enzymes, and trying to figure out what caused this patient to go into flash pulmonary edema. You make sure that the SAT remains more than 90%, and you can do by increasing FiO2 and increasing PEEP. PEEP can help left ventricle function and reduce pulmonary edema. For the improvement of left ventricle function, make sure that your rates are well controlled. Rule out acute coronary syndromes. You can use pressors or inotropes as required. You can decide to place a central line or swan to monitor cardiac output or central venous oxygen sats. You can use diuretics and afterload reducing agents as tolerated by the patient. In summary, make sure that you perform inspiratory pause daily and note peak and plateau pressures. Most of the vents now save this information, so learn how to get that information from the ventilator. Look at the flow time waveforms and make sure that the expiratory flows are reaching baseline. If not, perform an expiratory pause and calculate intrinsic PEEP. If you are called for peak pressure alarms or hypoxemia, make sure that there is no patient-vent asynchrony. Auscultate and suction the ET tube yourself. Perform inspiratory and expiratory pause and figure out peak, plateau, and intrinsic PEEP, and then run your differentials. Bedside ultrasound is a very useful tool in this regard, and I would suggest that you learn to do some basic diagnostic tests with these and order the other tests and treatment as per the underlying etiology. Thank you.